Welcome everybody back to the second part of the urinary system chapter. So here we go. We have looked at what's happening in the renal corpuscle, and as you see, the first statement here as a reminder of that 48 gallons per day glomerular filtration rate. This is so high that if nothing else happens in our kidneys, we would be dehydrated, parched dry in less than an hour. So obviously something else is happening. So the filtration is opposed by the reabsorption process, where the tubular portion of the nephron is working very hard to return most of that filtrate, most of that 48 gallons back into blood. This happens within microscopic distances, so we don't really feel that we would dehydrate, although we are filtering 48 gallons per day, because just a few cells away from the renal corpuscle, reabsorption is going like gangbusters. So we'll be talking about individual parts of the tubular portion of a nephron. We'll be starting with the proximal convoluted tubule, and this is where the rubber meets the road. We'll look into this in greater detail. The rest we also mention, and how this reabsorption happens is both active and passive processes, and we have to mention osmosis. Most of that 48 gallons is water, right? So osmosis need to be put into high gear in the tubular portion of the nephron. When we mention the filtering process, we mentioned that small proteins can enter into the filtrate. Our urine, it has very, very low protein levels, so a lot of those small proteins are taken out of this filtrate by pinocytosis. We're not going to mention any more of this. You would have to look back into chapter 3 to see that this is a vesicular transport mechanism. This is active transport, and it is taking a small droplet of filtrate loaded with proteins to the interstitial fluid. So I put this slide back in here. We are right here at the tip of this green arrow. This green arrow represents 48 gallons of filtrate per day. And here is this microscopic set of epithelial tubes, and they will do wonders for us. 47.5 gallons of fluids plus many solutes will be reabsorbed through this process number 2 here back into the blood. We will also mention sporadically tubular secretion. The volume of this material is very, very tiny. It doesn't compute into any measurable volumes. And the end result of these processes is, of course, urine, which is normally about half a gallon per day. So from 48 to half a gallon, this is where the reabsorption total 47.5 gallons per day need to come in. So this reabsorption needs to be quick and needs to be targeting only molecules useful for the body. We don't reabsorb waste products. Reabsorption, this is a regular scheme. In yellow is the filtrate. This is a forming urine stream just coming out of the renal corpuscle. Here's the blood where we want to reabsorb materials into, and here is the lining of the tubular portion of a nephron. And so this huge flow of 47.5 gallons sometime will travel through the cell, transcellular, and sometimes material moves in between cells the paracellular way. We will see, and this sentence, although it's not typed out here, will come up a number of times. Water follows sodium, and so sodium movement, reabsorption of sodium will be the initiating factor. We'll take a look at the sequence in a little bit, and we will see active transport, secondary active transport. In terms of water, the movement is only one kind, osmosis. Water will follow sodium and the rest of the solutes, and this will be a major driver for obligatory or everyday water reabsorption. This facultative water reabsorption, this will come up when we talk about production of concentrated urine. For most of the time, we'll be making normal dilute urine. Water will be moving in either case by osmosis. So I brought this sketch of the nephron. The first part that meets this real big gusher of 48 gallons per day is the proximal convoluted tubule. So we're going to see 100% reabsorption of glucose and amino acids. We're going to observe huge absorption percentages of electrolytes, bicarbonate, sodium, potassium, chloride, and 2/3 of water. So this is the most active part of the tubular portion of our nephron. Most of the reabsorption happens here. So here is my sketch of a proximal convoluted tubule cell. Here's the filtrate, and here's our target. We want to move all this useful material for the body back into the blood. This goes from top down. The sequence of events, the first action is active transport, pumping of sodium from the base or bottom of the cell into the interstitial fluid, and this sodium will be entering into the blood. So the consequence of this pump is that the cell will turn into a place of low concentration for sodium, because this pump is emptying sodium out of the cell into the blood. Sodium ions in the filtrate want to diffuse into the cell because now they see a place of low concentration. Remember, diffusion would drive molecules from a place of high to a place of low concentration. What helps movement of sodium into the cell actually called symporters. Symporters will be proteins that accept the movement of sodium, and as sodium is sticking to the symporter protein, that symporter protein will grab onto a glucose or grab onto amino acid. So these parallel purple and green lines label the work of symporters. This is the way our organic nutrients are reabsorbed here. Remember, these proximal convoluted cells, we reabsorb 100% of glucose, 100% of amino acids. The symporters represent secondary active transport. As you see, both sodium and glucose and amino acids will be diffusing into the blood after they enter the cell. With this huge movement of sodium, there will be a lot of positive charges accumulating in the cell, in the interstitial fluid, and just like a magnet, that will attract the electrolytes of the opposite charge. So negatively charged ions, chloride, phosphate, bicarbonate, are all attracted electrostatically, like a magnet, to the flow of sodium, and mostly by diffusion, these negatively charged ions will be streaming through the cell, just following where sodium goes, eventually reabsorbed into the blood. This movement of the negatively charged ions create a secondary electrostatic event, and other positively charged ions such as potassium, magnesium, calcium, they will be dragged along with the positively charged ions, and so either by diffusion, sometimes active transport, these ions will be moving into the cell and eventually into the interstitial fluid and into the blood. So the only molecule that's still left in the filtrate in large amount is water. Water always flows by osmosis from a place of low solute to the place of high solute, because all these molecules here represent solutes. Their concentration will be high in the cell, high in the interstitial fluid, and high in the blood, and water through water channels or in between the cells will be entering the cell by osmosis and following this flow of large amount of solutes, especially sodium, all the way to the blood. And when you look at this sketch, everything that we wanted to absorb is now on its way through the proximal convoluted tubule cell into the blood. Again, at least 2/3 of water, 70–90% of these ions, and 100% of amino acids and glucose are reabsorbed here in this early part of the tubular portion of a nephron in the proximal convoluted tubule. This is just a text version of that sketch. In addition to reabsorption, there is an opposite movement from the cells into the filtrate. We have antiporters, where sodium is moving into the proximal convoluted cell. Antiporters can grab onto a hydrogen ion and dump it into the filtrate. Remember, we constantly produce hydrogen ions. Removing these from our bodies is a major task of the urinary system, and so this is one active way of dumping, transporting hydrogen ions from the cell, from our body, into the filtrate, which is considered outside the body. So antiporters play a role in here. These antiporters can also transport ammonium ions. So the ammonia that's created by our liver and some other chemical processes in the body can also be stashed, pushed into the filtrate by antiporters in the proximal convoluted tubule. Our next segment is the loop of Henle, or the nephron loop. We'll be seeing two parts here. One where we'll be seeing normal reabsorption process. In the second part, in the ascending loop, you see the thicker wall. Water reabsorption will be inhibited here, and we'll see the consequence of this. So loop of Henle has a descending and an ascending part to it, ascending limb. A little different action happens in those two. So in the descending and ascending limbs of the loop of Henle, we see sodium pumping, and as a consequence of that, sodium, potassium, and chloride symporters reabsorb sodium and chloride mostly, from the filtrate into the blood. In the ascending limb, no water is absorbed, and it means that the ions will be leaving the filtrate, but water will be left in the filtrate, and the filtrate will getting more and more dilute for these ions. The next portion is the distal convoluted tubule. This also has an early and a late part. In the late part of this distal convoluted tubule and in the collecting duct, normally we don't have water reabsorption. So as you see these numbers, the saltiness numbers keep decreasing because sodium and chloride are reabsorbed to the outside of the tubule into the interstitial fluid, but water remains through most of these aspects of the nephron. So here's the picture in the early distal convoluted tubule. Sodium and chloride is absorbed through these symporters, active transport and secondary active transport, and the last portion of water is absorbed in the early distal convoluted tubule. In the late distal convoluted tubule and collecting duct, again, water is absorbed very poorly. So as a consequence, the urine is now getting more dilute. Water stays in the urine stream, but ions are being reabsorbed. So more and more dilute urine is the consequence here. What is causing the action in this portion of the nephron? We have principal cells. These cells are world famous because, as you see in a few minutes, hormones act on these cells. Sodium reabsorption and potassium secretion are all regulated by hormones acting on these principal cells. And here are even more famous cells. In chapter 27, we'll come back to these as major regulators of pH. The intercalated cells can reabsorb potassium. Most important is this bicarbonate and hydrogen secretion by the intercalated cells. We'll expand on this a great deal in chapter 27. And here is hormonal regulation. We have seen, especially if you think back in the blood pressure chapter, a blood volume, venous return, can be changed by forcing the kidneys to absorb more sodium and therefore more water. So here's angiotensin. This is a hormone that is in the business of increasing blood pressure, and in addition to changing glomerular filtration rate, it acts in the proximal convoluted tubule and increases sodium and water reabsorption into the blood, therefore increases blood pressure. Aldosterone acts now in the distal convoluted tubule on the principal cells and forces those cells to reabsorb more sodium and therefore more water. Aldosterone, we'll see this in chapter 27 too, is also a regulator of potassium levels in our blood. Aldosterone tells the principal cells secrete more potassium. We also have atrionatriuretic peptide. We have seen how this increases glomerular filtration rate, and in the tubular portion of the nephron, in the proximal convoluted tubule, it slows down sodium reabsorption, and when sodium is reabsorbed slow, then water is also slow to reabsorb, and therefore the excess water remains in the filtrate, is not reabsorbed, and large amount of water can be released from the blood So if we have such a huge blood volume that stretches the atria, that makes this hormone, just just by slowing down sodium and water reabsorption, uh, we can increase urine output and therefore decrease blood volume. We'll be seeing this in chapter 27 in a more functional context, antidiuretic hormone. This is acting on those principal cells as well. It is changing how much water can flow through those cells, and we'll be seeing the scenarios, whether it's dehydration by hyperthermia or diarrhea or blood loss. Antidiuretic hormone is leading to increased water reabsorption in the distal convoluted tubule and collecting ducts. So these are the hormones that act on our tubular portion of the nephron. And who can have more fun topic than talking about dilute versus concentrated urine? So this has a lot to do with our water management in the body. In chapter 27, we'll take again a more coordinated look at this. Suffice it to say that when we have proper water intake, we can afford to release half a gallon of water from our body. We're not going to miss it because we are well hydrated, and so dilute urine is formed. This is typical of our everyday action. On the other hand, if we are not drinking enough, if we are losing water through perspiration, diarrhea, our body will be jealously guarding the water and will not allow water to be released in the urine to such a degree. And so we will reclaim water from the forming urine stream, and the resulting urine will be the concentrated urine. This is all done at the command of antidiuretic hormone. This saves us from dehydration. So dilute urine, antidiuretic hormone level is low because we are well hydrated. Nothing has triggered our hypothalamus that will be changing antidiuretic hormone levels. So we are looking at the distal convoluted tubule and collecting ducts, not reabsorbing water, but only sodium and potassium and chloride. And so as those ions are pumped out from this forming urine here, we'll see the saltiness number decrease. There's less and less salt, sodium and chloride, and the product is dilute urine. So concentrated urine, here are some of the scenarios. We have, for some reason, a water deficit in the body, and we can replenish that missing water from the forming urine that's flowing through a collecting duct and the late distal convoluted tubule. So water will not be allowed to go into the urine. Concentrated urine is much smaller in volume, and therefore all that water that we're not peeing out is saved for our own body. Antidiuretic hormone is the major agent in this action. How is this formed? Instead of going through this text, let me explain this and the others on the following image. So here's our nephron, And this is a process where those juxtaglomerular nephrons play an important role. So the initial part of this water conservation measure forming concentrated urine actually starts with the loop of Henle. The longer the loop of Henle, the better it does this kind of a job. So you see different shades of blue here. This tells you just how salty the interstitial fluid is, and the reabsorption of sodium and chloride from the loop of Henle continues. And where does all that sodium and chloride goes? At least temporarily, it accumulates here in the interstitial fluid. And this blue solution is salty. It would be salty to the taste if we could taste it. So this salt buildup here is the way how the stage is set for forming concentrated urine. Antidiuretic hormone, when we are running low on water because of diarrhea or hyperthermia caused sweating, antidiuretic hormone will place aquaporin channels into the principal cells of the collecting ducts. And here you see some of these new aquaporins opening way for water to flow. Now, why would water rush out from this forming urine in the collecting ducts? Because of the saltiness. Water always moves to the place of a high solute concentration, or you can say it in a way, water follows sodium. There's a lot of sodium here, and water will rush out at tremendous speeds once we have the aquaporin channels placed courtesy of antidiuretic hormone into the wall of the collecting duct. So now we have a pathway for water to flow out, and water first comes into the interstitial fluid, and then it will be reabsorbed into the blood. So just by putting channels for the water into the collecting ducts, we are reclaiming water. What you see at the end of the collecting duct, at the end of the pyramid, is now concentrated urine, a highly concentrated salt concentration and waste product concentration in the urine. Besides this physiological scenario, there are clinical situations where increasing urine output is desirable. Diuretics is the name of the drugs that cause increased urine production. Many hypertension controlling medications contain some diuretics, so decreasing blood volume is one mechanism how we treat hypertension or how we control hypertension, but there are other situations as well. So how do these diuretics work? Pretty handy. We have to tell the nephrons not to absorb all that water, allow the water to stay in the urine stream so we can pee it out as increased urine volume. How do we convince the nephron to do that? Well, these drugs slow down sodium reabsorption, whether it's in the loop of Henle or in the distal convoluted tubule. Inhibition of sodium reabsorption is the mechanism. Sodium remains in the filtrate, and therefore water tends to stay with sodium. Again, water follows sodium. If sodium stays in the filtrate in these treated patients, water will stay with that too, and both excess sodium and excess water will be eliminated from a body in the form of increased urine flow. So diuretics act on the nephrons where water handling is influenced by movement of sodium. The last few slides are all about what to do now with this formed urine. In the renal sinus, which is not pictured here, in the ureter, in the bladder, and in the urethra, the urine composition is no longer altered. There's no more water reabsorption. We cannot add more sodium or take back more potassium. So these structures are no longer just the quality of the urine or the volume of the urine. They are just draining or storage structures. So ureters, they start from the renal pelvis and ends in the posterior aspect of the bladder. You can see the entry points. And the ureters have a wall rich in smooth muscle, very similar to small intestine, large intestine, esophagus. The movement peristalsis is created by that smooth muscle, and this is how we can push urine into the bladder even when gravity and hydrostatic pressure is not around. Think about how we can feel our bladders while we are sleeping. Gravity and hydrostatic pressure is not helping there. That's the best evidence that ureters with peristalsis, with the smooth muscle contraction, drop by drop, they are pushing urine into the bladder. The bladder, let's take a look at the gross anatomy. First, we see a storage organ, and we have maybe the most remarkable structure here is this trigon. There are a lot of stretch receptors are here, and the emptying of the bladder will be triggered mostly by stretch receptors located in this trigon area. It is smooth. The rest of the bladder has rugae, which helps with the expansion of this filling bladder. In terms of tissues, maybe you remember this from the tissue chapter way back in AMP1. Transitional epithelium lines not only the ureter but also the bladder, and this transitional epithelium allows the stretching, and this is a major advantage here in the bladder. So permits stretch is the function of the transitional epithelium. In this stretching, the cells and the mucus on top of them prevent urine seeping through this epithelial layer. This is the mucosa. You probably remember this from our digestive system. The muscularis is smooth muscle. Sometimes it's called the detrusor muscle, and we have some connective tissue in the bladder. With the urethra, we're going to come back to this in great detail in the reproductive system. In the female urinary system, the urethra is a fairly short tube leading to the urinary orifice. In males, it's a very different story. From the bladder, there's a long urethra, leads first through the prostate, then a tiny segment of muscles, and then through the entire penis to lead urine out of the body. So we have this prostatic, membranous, and spongy or penile urethra. And there is a sphincter at the very beginning of the urethra that controls urine flow. In this last slide, we'll be looking at the roles of the internal and external urethral sphincters in controlling urination. The micturition reflex has a lot of similarities to the defecation reflex. So here is a storage organ, just like the rectum was in the digestive system. The bladder has stretch receptors, and when those stretch receptors, mostly in the trigone, are activated by the filling of the bladder, a reflex arc will be activated. Just like with defecation, the coordination is in the spinal cord. Micturition or urination reflex is a parasympathetic reaction. Stretch receptors take nerve impulse to the spinal cord. Spinal cord will relay those nerve impulses to the smooth muscle of the bladder, and also opens the skeletal muscle and the smooth muscle sphincters, external and internal sphincters. Here is the internal urethral sphincter, and here's the external urethral sphincter. So before we were potty trained, the opening of these sphincters are automatic, and voiding of the bladder, urination, happens whenever stretch receptors trigger this reflex arc. Potty training includes the training of the brain. Just like with defecation, our consciously working part of the brain can override the reflex arc and the decision by the spinal cord. And so the effect of potty training is, while this reflex arch may open the internal urethral sphincter, which is smooth muscle, our consciously working part of the brain controls the skeletal muscle, external urethral sphincter, so we can postpone urination, just like we can postpone defecation by controlling a skeletal muscle sphincter. Once we are at an appropriate, socially acceptable place for urination, our brain will be giving the command for the external sphincter to open, and urination will be accomplished.